I am Dr. Kilpatrick, and today I'll walk you through a practical provider guide to using Burosumab, or Crysvita, in tumor-induced osteomalacia.
For patients with tumor-induced osteomalacia, or TIO, where the causative tumor cannot be located or surgically removed, Burosumab offers a targeted intervention. Sold under the brand name Crysvita, it is a monoclonal antibody that binds and neutralizes excess FGF23 proteins to correct severe hypophosphatemia. Administering this therapy requires a strict clinical protocol. In this guide, we will walk through the 4 necessary phases: pre-treatment setup, weight-based dosing calculations, routine monitoring and titration, and finally, pre-surgery management. Adhering to these steps ensures that this metabolic condition remains a strictly controlled and safely monitored disease state. Step 1 begins before the patient ever receives an injection. You must discontinue all of the patient's oral phosphate and active vitamin D analogs, such as calcitriol or paracalcitriol. This washout period needs to last a minimum of 1 full week prior to initiating Burosumab. Co-administering these medications creates an additive pharmacological effect that can trigger severe hyperphosphatemia. Once the week has passed, verify through a fasting lab draw that the patient's baseline serum phosphorus is confirmed to be below the normal age-appropriate reference range. You also need a baseline radiographic screening. Order a renal ultrasound to check the patient for any pre-existing nephrocalcinosis. Finally, check their kidney function. Burosumab must never be administered to patients with severe renal impairment, defined as an eGFR below 15 to 29 milliliters per minute. Skipping any of these baseline checks directly exposes the patient to severe systemic soft tissue calcification. Now we move to administration. Burosumab utilizes a weight-based dosing strategy, and the patient's age determines both their starting dose and their injection schedule. For adults, the starting dose is 0.3 milligrams per kilogram administered every 4 weeks. Adolescents aged 13 to 17 use that same 0.3 milligrams per kilogram starting dose, but they receive their injections every 2 weeks. For children aged 1 to 12, the starting dose is slightly higher at 0.4 milligrams per kilogram, also given every 2 weeks. All doses must be rounded to the nearest 10 milligrams. Notice the maximum limits: 90 milligrams for young children and 180 milligrams for adolescents and adults. There are 4 approved subcutaneous injection zones: the upper arm, the abdomen, the buttock, and the thigh. A single injection site cannot receive more than 1.5 milliliters of fluid. If your calculated dose requires a larger volume, you must split the dose and administer it across multiple rotated sites. Precise weight-based calculations and careful site rotation will maximize drug absorption while minimizing any severe injection site reactions. Once therapy begins, your primary clinical target is to maintain the patient's fasting serum phosphate at the lower end of the normal reference range for their age. To accurately measure the drug's peak effect, fasting serum phosphate must be drawn 2 weeks post-dose. If that 2-week check shows phosphate is still too low, you will initiate a step up. Increase the dose in increments of 0.2 to 0.5 milligrams per kilogram. However, do not make these dose adjustments more frequently than every 4 weeks. If the patient hits the normal reference range, simply maintain their current dose and schedule. If phosphate spikes above normal, you must withhold the next scheduled dose. Retest their levels in 2 weeks. Once serum phosphate drops back below the reference range, you can restart therapy at half the previous dose. This rigid cadence of testing at 2 weeks and adjusting at 4 weeks is your primary defense against causing ectopic mineralization. While adjusting the dose, monitor for the most common adverse events reported by TIO patients. These include tooth abscesses, muscle spasms, constipation, and local injection site reactions. Burosumab can also cause dizziness. Instruct your patients to exercise caution when driving or operating heavy machinery until they know how the medication affects them. Because of the antibody's elimination half-life, women of childbearing potential are required to use effective contraception throughout treatment and must continue it for at least 14 weeks after their final dose. In some cases, a patient's underlying tumor may eventually become localizable and operable. If a curative tumor resection is scheduled, Burosumab therapy must be interrupted. To allow the drug to properly clear from the bloodstream, skip the dose scheduled closest to the surgery. Because Burosumab has a 19-day half-life, this provides approximately a 4-week washout. Following the procedure, reinitiate therapy only if the patient's phosphate remains abnormally low. Strategic surgical pausing allows the medication to stabilize the patient until surgery provides a definitive cure. Mastering the washout, dosing, and lab timing protocols halts the progressive skeletal damage caused by TIO. This 48-week chart compares fully healed fractures and pseudofractures in Burosumab patients against a placebo group. In the continuous Burosumab regimen, we see a clear trajectory upward, reaching a 63.1% full healing rate by week 48. By following these precise administration guidelines, providers can help restore patient mobility, reduce reported pain levels, and improve overall quality of life.